Hello and welcome to CJJ's webinar on family-centered treatment, a community-based alternative to out-of-home placement. My name is Jonathan Litt, and I'm the Policy and Field Relations Associate at the Coalition for Juvenile Justice. Before I introduce today's speakers, I'd like to take a moment to discuss a few technical details. You will notice that all participants are and will remain muted throughout the webinar. Presenters will take questions at the end of the presentation. You may submit your questions at any time by typing in your questions into the questions box in your control panel. You will also notice that there are two resources available for downloading under the Handouts menu in your control panel. You can click a resource to download it. If you don't see the documents in your control panel, click the plus sign next to Handouts in your control panel to drop down the menu option. We are recording this webinar. The recording, PowerPoint, and resources will be posted on CJJ's website within 24 hours. With that, it's my honor and privilege to welcome today's speakers, Bill Painter, Tim Woods, Charlotte Lynn Bright, and John Irvine. Bill Painter serves as the Senior Director of Clinical Practice within the Mentor Network's Family and Child Services Center of Excellence and providing leadership for the ongoing advancement of family-centered treatment, an evidence-based and best practice model of in-home family preservation services. As the leading developer of the family-centered treatment, Bill has worked on numerous state and federal responses to child abuse and neglect issues and impacted policy designed to address treatment methodology. Tim Wood serves as the Executive Director of the Family-Centered Treatment Foundation, which owns the Family-Centered Treatment and the related training program, Wheels of Change. Prior to joining the foundation, Tim worked in utilization review for Value Options, Inc., and as a director at the Institute for Family-Centered Services. Tim has served as a practitioner, trainer, supervisor, and has assisted with the ongoing development and oversight of the FCT model. Charlotte Lynn Bright is an associate professor at the University of Maryland School of Social Work. She has a range of research experience within the juvenile justice and child welfare systems on such issues such as gender equity, trauma, service outcomes, and the implementation of best practices. Her practice experience centered on providing case management, clinical services, and administration to youth and families through the child welfare and juvenile justice systems. John Irvine is the Director of the Office of Research and Evaluation at the Maryland Department of Juvenile Services, which manages all agency data reporting, research, and program evaluation projects, and ensures that policy and programming are evidence-based and reflect best practices. He has served in the Maryland government for 15 years with a focus on strategic planning, performance measurement, program and policy evaluation, and has coordinated practical research initiatives with academic and other research partners. And with that, I'd like to turn it over to our first presenter, Bill.
Hello, everyone. The purpose of our presentation today, you can go to the next slide. The purpose of our presentation today is to examine family-centered treatment in some detail, and very specifically to evaluate or to look at the evaluation that was done through the University of Maryland School of Social Work. That was a long-term and large-scale study to look at sustainability. It is our intention that, or contention that, in order for family systems to change, the work that needs to be done should be done with the whole family. So often, the public sector will contract for work in the community-based process, which seems to be the alternative of choice now in the public sector. But so often that work ends up being very client-centered, and it is our contention that for long-term sustainability, we need to be able to do work that is with the whole family. So our concern is that the public sector nationally is supporting things that in the long run can be temporary, and it is our goal to, as with all service lines, to become effective from a long-term sustainability process. The next slide, please. John Irvine is going to cover how Maryland DGS made this service happen and the reason for services. Tim Wood, as the Executive Director of Family Center Treatment Foundation, is going to describe the licensing agency that owns the model and some of the process that public sector or private agencies might go through to have access to the model. Charlotte Bright will give some of the findings of the independent evaluation, and then I will describe in some more detail the model components and some of the implications of the findings. As mentioned, the handouts include, that's the next slide, the executive summary of the independent evaluation, a brief description of family-centered treatment, and a diagram demonstrating the family-centered treatment methodology. Next slide. So this picture represents what we're all after, is some long-term effects and sustainable change, and certainly is the goal of treatment for family-centered treatment. And we hope to examine in the course of the next hour some things about family-centered treatment, but more specifically the outcomes of the research done by the University of Maryland in conjunction with a cooperation with Maryland DGAS. And with that, I'll turn it over to John Irvine.
Thanks a lot, Bill, and thanks to Jonathan and the Coalition for having me today. I'm the Director of Research and Program Evaluation at an executive level agency, the Maryland Department of Juvenile Services. If you could bring up the next slide. Our agency has a fairly broad scope of authority in Maryland. Next slide, please. Where we have the opportunity to screen intake cases at arrest before they get to court. We operate detention centers, and we screen when police want a youth detained. We have a detention screener. So we've got a front door for the detention process. We operate also detention alternatives as part of the Juvenile Detention Alternatives Project through the Casey Foundation for kids who would otherwise be detained before their hearing. We also do some diversion, what we call pre-court, for cases that we don't think are serious enough to go to court. We can have an agreement with the family to have a fairly low level of involvement without the court, but still have a case manager. The only part of the system in Maryland that we don't run is the courts. They make the decision on adjudication, but we are in a good position in Maryland to make an educated recommendation based on a fairly sophisticated assessment process as to what we think the best course of treatment is, whether it's in-home or out-of-home. For those cases that the court adjudicates to probation, we also, the probation officers work for us in all of our regional offices. We operate the committed end of the system in Maryland also, either running or contracting out programs for committed kids who are committed to our agency. Maryland has had a long-standing principle of using the least restrictive environment for committed youth, so we have built up over the last few decades a fairly broad array of out-of-home communities opportunities for kids, group homes, treatment, foster care, residential treatment centers, substance abuse, et cetera, that are not secure commitments, but they're still commitments. We do believe, and we've done some work with the Casey Foundation, that even those committed kids are relatively low risk, and we believe that we should be working with families to keep kids out of commitment altogether and keep them on the probation end of the spectrum. So we've built up over the last decade in-home services to serve youth on probation, specifically designed to keep them out of the committed end of the system. We've developed what we call a per diem process, where a provider will get a rate, a per diem rate, and for all the days a youth is being served, they get a certain set amount. It started with the residential programs, and it expanded on our non-residential side. Our major resources that we've used and built up over the years in the in-home side of things, we have functional family therapy, multisystemic therapy, next slide, thank you, which are evidence-based programs. There was a lot of support from the governor's office to roll those out across Maryland, both for our youth and also youth in the child welfare side of things. In 2004, we entered a contract with the Institute for Family-Centered Services to provide family-centered treatment as another option to work with families for youth on probation. And I have to say there are a few cases that we work with at this level on the pre-court side, so as diverted cases, very few of those, but we also do some for aftercare for kids who are re-entering back home after a committed placement. So the main focus, again, is on the probation side, but we do a little bit of diversion and a little bit of re-entry. We are covering most of Maryland with these programs. FFT serves kids in 12 counties, multi-systemic therapy in 5 counties, and family-centered treatment in 14 counties, which covers almost all of the western shore of Maryland. We don't have FCT on the eastern shore as of now. Because we are a executive level agency that basically covers the whole system in Maryland from arrest through aftercare, we also have a data system that captures management information on the history of youth's involvement in the juvenile system, on their offenses, their placements, and the services that we've provided to them. So it's a rich research data set that we can use to partner with university and other folks to do program evaluation. So we were in a very good position to work with the University of Maryland on the project that you'll hear about next, where we've got data on recidivism in the juvenile system. We have a good working relationship with our adult criminal justice system to get adult recidivism data that all go into the mix on these program evaluation projects. And I think with that, I will hand it back over to Tim Wood. Thank you very much.
Thank you, John. Appreciate it. Hello, everyone. This is Tim Wood. I'm the Executive Director of the FCT Foundation. FCTF is a nonprofit 501c3 organization charged with licensing, advancement, innovation, training, monitoring, oversight, and operation of the FCT model, essentially all things FCT. Additionally, the foundation seeks to further the research and understanding of the model in effective home-based family practices through collaborations with independent third parties and through various empirical studies. Of note, we as the FCT Foundation are not a direct service provider of the FCT model. Instead, we serve as a purveyor or a third-party overseer of programs, providing the direct service. In this role as the liaison is often welcomed by stakeholders who wish to gain more objective information, again, not being a direct provider, around the FCT model. Next slide, please. This is a snapshot of the current FCT provider network nationally and locations. Of primary importance to the FCT Foundation is working to ensure that the research and practice-based evidence, more of which we'll learn about later, can be replicated across all sites. And success in replication is based on a significant number of factors that broadly include the program itself, the culture of various states, different funding sources, population served, etc. Currently, we have 12 licensed programs with multiple sites across 9 states, and at this point, greater than 35 sites across the country. Next slide, please. Implementation science is really the backbone of the foundation and how we do replicate FCT. To produce gainful outcomes, it's not just enough to engage a clinical approach with a program implementing FCT. The FCT Foundation utilizes a design process of implementation, capturing implementation science research, best practices, and implementation practice-based evidence that has been learned and that we've learned from site replications of the model across the country. The framework for implementation process is first knowing where we are, meaning diagnosing a program in their phase of implementation, and then knowing how to approach that particular organization or program based on the phase that we've assessed or diagnosed them in. 2, knowing what to work on, and this is accomplished through design tools that explore implementation drivers. And these drivers include cultural, competency, organizational, and leadership, which require installation, tracking, and sustainability, and are broken out into well over 100 components and subcomponents within those 4 drivers. So again, this is something that the FCT Foundation works individually with each program, site, or organization. And then third, knowing who needs to be engaged to make the model effective. Implementation teams consist of various stakeholders, including those outside of the program, those such as referring sources, state funders, etc., that are critical for success. Often programs and stakeholders don't take into account the number of resources and different departments required to keep a program sustainable. such as HR personnel or the QMS staff. But it's recognized and brought to light in SCT implementation that all members of a program have some kind of say or function within effective rollout of the clinical model. Next slide, please. This is the aforementioned implementation process. It all starts at the bottom with a readiness assessment to determine a program or a site within a program's feasibility of being able to replicate. From there, with a pretty rigid undertaking, an organization is licensed and a plan for implementation takes place. And throughout the process, key implementation tools are used to objectively measure how the program or site is implementing and where the program improvements need to occur or potentially be built within an organization. If sites and systems are consistent and they adhere to the process expected across all FCT providers, including strict adherence to the fidelity measures and dosage, we purport that gainful outcomes can be achieved. Next slide, please. This is a brief snapshot of the licensing standards. Embedded in the implementation framework are the licensing standards. And this slide provides us with an extraction of some of the key standards for successful replication that all providers need to follow. Within these standards, there are certain benchmarks and subcomponents, all of which are tracked and built up within an organization to ensure continuity across the program. And they include training and certification of the ground level clinicians, supervisor certification, training and tracking, fidelity and dosage adherence, ensuring that the families in receipt of service are getting what the model purports, as well as data extraction and clinical outcome performance, and finally implementation process and measures to ensure that everyone is following the same program. Next slide, please. I'm pulling a couple of the licensing standards that I frequently get asked about or generate questions for us to look at. The first one extracted from the previous slide is the standard around training and certification of the frontline clinicians. The FCT training process runs through the published and now digital online platform called the Wheels of Change. The Wheels of Change includes courses for all things FCT and encompasses an intensive curriculum with interactive learning, required off-site reading for the clinicians, video demonstrations of clinical practice, and group discussion and testing. Additionally, to achieve full certification, clinicians must demonstrate an ability to perform key components of the model in the field. The field testing is designed to engage clinicians in real-life experiences with veteran trainers or supervisors overseeing this process, and approaches field observation as a developmental charge for the clinician, meaning it's not strictly a testing atmosphere, but also one of development and learning for the clinicians. Individual site and program data is continuously tracked as part of this and as part of licensing by the foundation, who then issues and monitors certifications and tracks certification statuses as long as clinicians remain certified. Next slide, please. And the other licensing requirement that I pulled out was the supervision process. Program site success has a lot of correlation to the effectiveness of the supervisor overseeing it, and this remains very true for the FCT model. And here we've highlighted the supervision training standard, where FCT supervisors are expected to go through their own supervision certification process as well. This is also housed in that Wheels of Change platform. And the supervisor curriculum consists also of online learning, video review, group discussion, live observation, checkoffs or video review checkoffs of the supervisor in supervision with their clinicians. Specifically, the supervisors are reviewed on their ability to effectively coach their clinicians in the 4 phases of treatment, how they develop the staff to get through the phases of treatment, and how the supervisors are able to diagnose their staff in competence and commitment of their work. Completion of this produces an FCT supervisor certification, and all the data information, again, is tracked and housed by the FCT Foundation across all programs. So those are 2 of the many licensing standards that are encompassed within the model. And if there are additional questions around the foundation, implementation, or licensing, I'm certainly happy to connect again around that. Next slide, please. And I am now pleased to turn this presentation over to Charlotte Bright.
Thank you, Tim, and thank you everyone for attending, and especially Jonathan for facilitating this opportunity to share what we've learned. I am the principal investigator of an external evaluation of family-centered treatment, and I'm going to speak just briefly about methods and key findings of how we did what we did and what we found. Next slide, please. Our intention here was to add to the evidence based on family-centered treatment and learn more about whether and how it might be effective. We wanted to apply rigorous methods so that we could study this intervention, and we wanted to use an objective research team, namely a team of researchers who did not have a particular stake or investment in the success of family-centered treatment or any alternative strategy for intervention. Our three primary aims are listed on the slide. We wanted to compare recidivism rates for youth in family-centered treatment versus youth in group care, and also compare costs of service provision between those two types of intervention. A third aim was to explore implementation factors in relation to these outcomes. I'm not going to go into the implementation results in any depth just because of time, but I believe Bill will be referring to a few of those findings later in the presentation. Next slide, please. Our sample of youth were those who were adjudicated delinquent involved with the Maryland Department of Juvenile Services. As John mentioned, FCT does serve some youth who are either diverted or in aftercare, but we excluded those to look at this, as he called it, probation sample. In order to get a large sample and look at youth over time, we extracted data from fiscal years 2009 to 2013. I'll talk about the matching process in a moment, but we also looked at, as a comparison group, individuals who were in group homes or treatment group homes in the communities during the same fiscal years. Our outcomes of interest were all measured after the end of treatment, regardless of whether the youth was in the family-centered treatment group or in the group home group. We looked at readjudication or commitment within the juvenile justice system in Maryland, and then we also extended our findings into the adult criminal justice system to look at conviction or receipt of a sentence of incarceration, including suspended sentences. And then we compared costs of service provision between the two conditions, family-centered treatment and group care. Next slide, please. In order to create a meaningful comparison, we used a technique called propensity score matching. And that's a statistical strategy that we use to create equivalent groups. And so we matched individuals from the family-centered treatment group with comparable youth who had been in group homes or treatment group homes during the same period of time. And after we completed our matching procedures, we ended up with a sample of kids in group homes who were not significantly different from youth who received family-centered treatment on a series of background characteristics. For our data analysis, we used what we call time-to-event models or survival analysis. In our case, we specifically used Cox regression models, and that allowed us to control for the consideration that youth had different times at risk of the outcome. What that means is some youth could be could finish treatment and then one day later the study period ended. Some youth, by contrast, could be could finish treatment years before the end of the study treatment, and so the study period rather. And so we were able to statistically control for the different times at risk. Next slide, please. This table just shows who we ended up with in our sample after matching. And you will see some slight differences in the groups, but those are not statistically significant differences. And let's go on to the next slide. This information tells us a little bit about our first aim, which is to compare recidivism findings. In our first outcome of interest, we found that there was no statistically significant difference between the family-centered treatment group and the group home group in terms of readjudication after discharge from treatment. That is, both groups were statistically equally likely to experience readjudication after discharge. However, we did find a statistically significant difference in commitment findings. So the family-centered treatment recipients were much less likely, significantly less likely, to experience commitment within the juvenile justice system following discharge from treatment. Next slide. On this slide, you can see the findings for the adult criminal justice outcomes we examined. And in these, we continued the findings that family-centered treatment did better in terms of performance with relation to outcomes than group homes did. So in both conviction in the adult system and a sentence of incarceration in the adult system, we found that the family-centered treatment group was significantly less likely to experience either outcome following discharge from treatment. Next slide, please. This bar chart is just a visual demonstration of the frequencies of each outcome we looked at for each group. And what you can see here is what I just explained, that on the left-hand side, we've got adjudication in the juvenile justice system, and there is no difference between groups. However, with each of the other outcomes, we see a difference between groups where the family-centered treatment group has better outcomes than the group home groups. Next slide, please. In terms of cost findings, we were very interested in learning more about what each intervention costs on average per youth. And our primary finding was that family-centered treatment costs substantially less, about $30,000 less per youth than group homes as an intervention. This cost difference is largely driven by two things: shorter average lengths of stay and lower average daily cost. Next slide, please. So to summarize these core findings that I just reviewed, family-centered treatment in Maryland was associated with better outcomes than group homes on 3 of the indicators we were interested in looking at. And that is commitment within the juvenile justice system, conviction and incarceration within the adult criminal justice system. However, family-centered treatment was not significantly different from group homes on readjudication within the juvenile justice system. And then finally, we found that costs were lower for family-centered treatment versus group homes. And that's lower per diem and shorter treatment times. And then finally, I just wanted to indicate that I'm the person talking, but that many of us participated as members of the evaluation team here at the University of Maryland. Also, there was substantial investment, as John Irvine mentioned, on behalf of the departments, and we appreciate all of their involvement. And with that, I will turn this over to Bill Painter. Thank you.
Hello, everyone. This is Bill Painter, and I will walk through briefly a little bit of the detail around the model component to hopefully provide some information that will be useful in understanding what each client received, and then we'll review the findings again and discuss maybe some implications of the findings. The actual study itself will be available, I mentioned this at the end, on the University of Maryland Institute for Innovations and Implementation website at some point in the future. If you need a copy of that immediately, then you can certainly contact myself or Charlotte, and the executive summary of those findings are one of the handouts. The theoretical framework for family-centered treatment really goes back to an eco-structural family therapy approach, but not limited to trying to coach and train people how to behave differently, but emotionally focused therapy approach in looking at what can be done with families that are clients within families that are immobilized in their ability to change due to past trauma. Next slide, please. How does family-centered treatment work? It works very similar to most community-based services that go into the home and work with families. There's some nuances that we think are different. I hope to be able to focus over the next few slides, but definitely the most important facet of it that we're concerned about is working with the family as a unit, as defined by the family, with any kind of family that would be available. Meet with them in the day in their home, primarily at the days of the week and times of day that are convenient for them, and certainly offering those days of the week and times of day in order to assist them with evaluating how they're functioning at different times of their life as a family system, and then support them in real life timing that may, in some cases, be early a.m. getting kids off to school, or late night on weekend or evenings getting kids to bed, and to settle down. We really focused on scheduling sessions that get the clinician involved during the most troublesome, difficult times, and then the 24/7 on-call crisis that, again, is common for most community-based services is part of the model, but one of the things that we do try to maintain is that person on call is a person they're very familiar with. It's the family and their primary worker most of the time. Multiple hour sessions are part of the model, as Tim was mentioning, some of the dosage that was utilized, some of the data that was utilized to determine the frequency and intensity of sessions several times a week to avoid a start-stop process. That means the frequency had to be several times a week, and then to give them time to actually work on making changes that need to be a multiple-hour session. And then I think one of the most important things about family-centered treatment is that it is not a talk therapy approach. It is really putting family members and family systems in an opportunity to practice behaving differently. And these weekly enactments are integral to the process and not secondary. Next slide, please. So quickly, the primary stages or phases of family-centered treatment are similar to other models. Some nuances and differences I'll explain later. But briefly, joining and assessment is combined into one phase, restructuring another phase, value change. Valuing our changes is another phase, and then generalization is the final phase of treatment. Average length of treatment has borne out to be about 6 months, although it's designed individually for families, and it can be much shorter or longer depending on the needs of the family and the funding available. Trauma treatment is integrated at any phase or juncture in treatment when such as brought to the surface by the family's inability to integrate changes behaviorally due to some emotional blockages. Next slide, please. So what is meant by sustainable change? I like this slide because it kind of shows the metamorphosis of a family. They can go through dramatic change. We believe that. We know that. The history of family-centered treatment goes back to working with folks that started it. We're working in residential facilities with kids and adolescents that had long histories of disruption and inability to function within a family system, and really building upon a belief system that they were great individuals and had much to offer one another. And so they were integrated into a peers helping peer process. And the desire was to bring that kind of focus and perspective to working with whole families. And that was the mission and vision of the original founders and beginners of the family-centered treatment model. And so it comes from that innate perspective that change is possible, and that putting folks in a position to practice behaving differently can help them establish a new and accepted way of living that will work for them in the future. Next slide, please. Creating this change does create some huge obstacles. That is without saying. This picture kind of demonstrates some of the perspectives that society as a whole has around the clients and families that we're working with, and a belief that they're not able to change. And particularly as we look at some of these particular populations that are specific populations that were in the study, it's exciting to be able to know that even with the obstacles, change does occur. Next slide. So one of the first obstacles is to be able to engage families into treatment. Often the families referred have had multiple types of services available to them, and perhaps inappropriately defined as resistant and oppositional to services. But the reality is that we've learned through families and treatment, and it being a model that was developed by practitioners, that the real life world of families is such that we as a clinician can have a great ability to diagnose what they need, and even or diagnose what's hurting them and harming them in their functioning as a family, and a great ability to design what process that they really need. But we have to be able to partner. We can have all the knowledge in the world and the greatest insight in the world and a solution for them, but without that partnership and engaging them into treatment, then they're stuck behind an obstacle that we saw in the previous slide. So some of what makes this work is a belief that is our privilege to work with families and not a right, that treatment and change is their choice and not something that can be forced on them. And then we give them many guarantees about how we will behave with them that really focus on respect and dignity to them, and determine that as perhaps the most integral component to the process of what we do. Certainly is something we do with them, is not what we do to them or for them. come back to this belief that we cannot correct folks until we connect with them. Next slide, please. So I won't go through this. You will have access to this with your ability to have access to the PowerPoint. But the first phase certainly is joining and assessment. And again, it comes from a belief system that people are people, and as we approach people with dignity and respect and value them, then the ability to partner with them for change is so critical. And while assessment is a big part of this, we also have found as practitioners that our ability to put them in a position of having the information about themselves rather than other people scoring and scaling them is more indicative of the opportunity they're going to take for change than anything else. So joining is a crucial part of what we do, and it really means that we have to spend lots of time training and coaching and supervising staff on how to join in ways that meet families where they are and in using their vernacular in their currency. Next slide, please. And the assessment process is one that's participatory, it is fun, and it puts the family in charge of the information. And so all aspects of the FCT assessment process give them more information for controlling their life and identifying what they want to change as a family system. It's both individualized for individual members of the family and then integrates all family members into some components of assessment that allow them to demonstrate what's working and not working for them. Again, focused on the belief system that for us to be able to move forward, we have to partner successfully. So one of our goals in the first phase of treatment, or the primary aim of the first phase of treatment, is to gain enough trust that they're willing to try a suggestion that we might offer. Next slide, please. Another nuance of family-centered treatment is that for families that are seemingly unable to make changes, even though we are offering many, many suggestions for change, we don't discharge and count them as failures, but take a deeper look and say that there are often emotional blockages due to past pain that may prevent their ability to integrate some of the suggestions for change. And so being able and willing and having staff that are trained in their ability to take that divergent trail to work with folks individually or collectively around their past pain and trauma is integral to the model, and not and avoid at all costs discharging folks or ending their treatment because they don't seem to be able to make changes. Next slide, please. Restructuring, of course, then after they have been able to trust the clinician enough to take the suggestions and try them, is really just to practice behaving differently. It can take two different forms. It can be a diagnostic enactment or practicing process where the clinician has designed a task for them based on their past understandings and what they want to change, and they practice it in on their own or in the presence of the clinician, or an intervention enactment where an event has just naturally occurred that allows them to receive some coaching and suggestions around what they might do differently and how they might behave differently. So there are two distinct types of an enactment or practicing behaving differently that are occurring in this phase, but it's really the design and aim of this phase that they get some experience in behaving differently. Next phase. Next slide, rather. This is just more around some of the detail around restructuring, and in the preservation of time I'll move forward, but you can go back and look at this in some detail that describes the importance of determining new strategies as a family system, and not something that we do to families, but rather something we do with them. Next slide, please. We have to evaluate sometimes why folks start changing, and lots of models would plan towards termination once change has occurred and life is functioning much better for a family system. Being a practitioner-developed model, we learned through experience that ending services prematurely just because they've made changes in the way they function was often a precursor or a predictor that they would be back into treatment, in time. So it forced us to evaluate why are folks making change, and we can often discover that they're making change sometimes to conform or comply and get the system out of their life, or the neighbor to be quiet, or the school to quit calling, or they could be that they like the clinician and really want to please them or please others involved. It could be they're just avoiding conflict, and it could be that they're wanting to remove the oversight of or external power involved in their lives and get their own life back without the system involved. But those reasons for change in and of themselves are not a predictor that the changes can be sustainable. Next slide. Next slide, please. So if exit or discharge occurs before the client or family owns that change, then what is likely to occur? It's just like sand drifting through fingers, and it's not valued enough for them to maintain it once the clinician and the work is out of their home. Next slide, please. So the phase of treatment that is distinctive of family-centered treatment is called valuing our changes, and it's really designed around putting the family in some value conflict around the changes that they have made. It requires the clinician to change their style and their approach with the family and how they respond to them when they reach out for help, or how they respond to them when they're there for sessions, and even when they are practicing something new, putting them in a position to evaluate, why are they willing to try something new. So it is an ironic process, but it's really the juncture where the changes have a chance to be solidified for the family and really integrated into their future thinking if it's something they have decided and determined at this phase of treatment that they really want to keep. Next slide, please. And here's some of the details of just what I said, that it really ensures that the sustainability goes beyond the initial treatment. And it really is some cues for the clinician as to what they can do differently during this phase that's going to look and feel significantly different to the family than what has occurred for them in other phases of treatment by the clinician. Next slide, please. Then finally, then we move into generalization, and that is the phase at which we really work to prepare them for the future, put them in a position to not only predict how they're going to handle things in the future based on what has happened in the past, but more importantly, to predict the reality of changes that are going to occur within their family system during based on family life cycle changes, developmental changes of children, and even venture to predict or think about the things that maybe haven't happened in the past, but they could happen, or maybe they're worse fears. So it does allow them to develop a plan and roadmap for the future even after treatment has ended. And one of the things that is integral to them being able to discover they have the strength to face the future is demonstrated on the next slide. And that is a giving back project that is integrated into the model. And this allows them to really understand and discover some of the things that we have seen in them all along, even from inception of our work with them, that they really are strong people and have a great success internalized and they can get a chance to see what that really looks like as they do a giving project. They design it, coordinate it, and implement it under the support of with the support of the clinician, but really as a family system. It is a demonstratable process of how they're now functioning differently as a system. So this is one of our strongest opportunities for families to integrate the reality that they, in fact, have made some significant changes. Next slide, please. Some of the limitations are that it does require a family to work with, and the primary focus is with the family system, not psychiatric or medical. Next slide, please. As Tim mentioned, there is a competency-based training and recertification process for clinicians that I won't review again just for time's sake. Next slide, please. And then it's often been said that a model is only as good as the agency that implements it. And we kind of take that a little bit further and say a model is only as good as the supervisor is in providing supervision around the model. Training itself is significant and wonderful, but it alone doesn't guarantee that the clinician is going to do anything different than what they would have learned in school. Next slide, please. So FCT does require some standardization around the management and supervision system that Tim mentioned earlier, and because of this intensity of supervision, both individual and peer or team supervision, we find that workers get a significant amount of supervision per week. Next slide, please. The other part that Tim mentioned was the fidelity to the model and evaluating the adherence to the 16 components that are involved in the 4 phases of treatment. And then the supervision is also evaluated relative to following some phase of treatment-specific aspects of supervision. Next slide, please. So as we wind down here, let's look at some of the evaluation of the outcomes and implications, and then we'll take some questions. Next slide, please. One of the things Charlotte indicated early is that this was a large sample size. Over 2,600 youth were involved in the evaluation, and then even after the propensity score matching, we ended up with over 1,246 youth who started FCT that were involved in the match sample of 1,441 youth that were in group or treatment groups. The outcomes of interest to the juvenile justice system were evaluated, as she said, through a Cox regression approach, but that means that some clients were evaluated up to 5 years post-treatment, and I think most significantly, in addition to the long study period, was that it follows a significant number even into the adult system as they aged past 18. Next slide, please. The population characteristics, I won't go through in all the detail, but I think it is extremely significant to understand that the majority, 75%, are between the ages 15 and 17, and the average age at admission was over 16, just over 16. The majority of youth were male, 75%, and the majority of youth were African American and Black, 67%. And then we see that this is across rural, urban, and suburban settings, and that all youth had been adjudicated and had an average of 1.7 prior committed residential placements, even prior to involvement in either program. Next slide, please. So that's a significant understanding, provides significant information when you look at the population. And then in context then of what the model is, it was not developed and tested in a controlled laboratory setting, considered to be practitioner-developed or provider-developed model of practice. This was an effectiveness study, real-life implementation, not an efficacy study. In other words, it was not controlled with selecting the best staff or any kind of exclusionary criteria for the youth involved. Because there was no reject and no reject policy involved with FCT, it does mean that this study is highly rigorous in the sense of non-exclusionary and all takers. So both from the staff perspective and the youth referred is everyone that you can think of. And then another interesting aspect of the one group analysis was that the average fidelity of the specific treatment activities exceeded 75% during the fiscal years that we had electronic data available, 2011 through 2013. And then I think more significant than any of the one group study information is that over 85% of the sample met the definition of engaged in treatment. It's 11 or more direct contacts. Next slide, please. And then just as a repeat of the results again. Next slide, please. So how do we make sense of these findings? First of all, as Charlotte indicated, there was no significance in the outcomes and the readjudication rates post-treatment for those youth that had not aged into the adult system. However, there were significant difference in the commitment rates for the same youth, and significantly fewer youth receiving FCT were committed than youth in group care. I've often been asked, how come that is, and without being able to have any specific analysis of what happens in each court or a recommendation to the court post-treatment, I would have to say that our goal with FCT has been all along to create change in the family system, and our hope is that the family system can better handle whatever life throws at them post-treatment. And so we can't guarantee the child's not going to reoffend or recommit, as none of us can, but our goal and intent is to enable the family to be able to better handle it. So just from anecdotal kind of an analysis, that's what I'm hoping what this means. The FCT participants that did age into the adult system, there was significant difference in the arrest and conviction and the incarceration. And then significant difference, as Charlotte mentioned, in the length of stay and lower daily cost. And as you can see, even post-treatment, the first 12 months after the start of each intervention, FCT costs were estimated $41,000 plus some change less than per youth. Next slide, please. So I would say take away these findings, reach out to anyone you want to discuss this with, but for a population that's often considered lost or resistant to treatment, family-centered treatment was proven significantly effective when compared to out-of-home treatment in preventing commitment to out-of-home placements post-treatment. And as I said earlier, some of these clients were evaluated up to 5 years post-treatment. Following the subset of this population that aged into adulthood, significantly effective in preventing both reoffense from commitment and at significant savings. I hope our dream, our belief is that this is being provided to create some sustainable results for families, and we're thankful and appreciative of the juvenile justice system in Maryland and University of Maryland School of Social Work doing the research that provides some evidence that these results were sustainable, something we all hope for. Next slide, please. So again, feel free to reach out for contact with the foundation if you're interested in the model, with Charlotte if you're interested in more information around the work they can do, or the John Irvine with the Department of Juvenile Services there in Maryland. I'm certainly available to talk with you as well or respond to an email, and then the full study will be available at some point in the near future through the University of Maryland Institute for Implementation and Innovation website. And with that, I'll open up to questions, and particularly if you have any for Charlotte. She has to jump to another webinar in a few minutes, so we'll be glad to take some questions.
Thanks, Bill. So we'll be taking questions now from participants. Again, you can type in your questions into the question box if you haven't already done so. We'll probably give it a minute for questions to kind of filter through. But I did have one question that popped up immediately, and I thought I'd share it with Charlotte. And that question is, can you speculate or hypothesize why FCT had an effect on adult outcomes and some of the juvenile outcomes and the differences in those?
That's an excellent question, and I appreciate the use of the term speculate because that's what I'll be doing. But one thing that we looked at was longer-term outcomes, and especially longer-term outcomes with older youth. And we found some information that suggests that FCT may work particularly well with older youth, those 16 or over at the time of service initiation. And so it could be that those are the kids, those are the youth who are most likely to be aging into the adult system during the study period, and those might be the youth for whom this practice was most effective in Maryland. Like I said, that's somewhat speculative, but we do have some data supporting it. That's my primary takeaway from that question. Bill might have something else to add.
No, I think the data speaks for itself, so I think you're on target there.
Okay, another question for you, Charlotte, is were you able to compare the outcome findings for urban versus suburban versus rural youth? And if so, did you notice any significant differences?
That's a great question. Unfortunately, the answer is no, we didn't, because we included those characteristics in our propensity score matching process. And so by doing so, we created these equivalent groups in terms of urban, suburban, and rural, and then we couldn't use those as bases for comparison in the final analysis because we had sort of created this artificial statistical constraint that the groups would be equal in terms of their urbanicity. So in this study, we did not look at that for the reason that we wanted to create the most equivalent groups we could.
Okay. Thanks, Charlotte. And I think this is a question for Tim, maybe. In terms of the 6 phases of implementation, are there any particular phases that different sites have sort of gotten hung up on or isn't particularly challenging for them?
I don't know that any one particular phase stands out. However, there are certainly certain blocks that we try to become aware of. Implementation is not a quick process, and to rush it, I think, is somewhat foolish. So we pay very close attention. Again, we try to be objective in how we're measuring how an organization goes through phases of implementation. The other caveat with that is that an organization, suppose they have a massive shift in management change or leadership change, could theoretically move backwards in a phase of implementation as well. And we don't look at that necessarily as a negative. It just becomes how we reevaluate how to approach that organization. So to answer your question, no, I don't believe there's a particular phase of implementation that organizations get tripped up on, but some do take longer to achieve than others.
All right. Thank you, Tim. And this may be a question for John. Did the department contract with FCT services or develop its own clinical FCT staff?
We contracted that out. We do not run any FCT in Maryland. We contract with the Institute for Family-Centered Services.
Okay.
So we didn't develop any specific model for Maryland ourselves.
Okay. All right. Well, it looks like we have run out of time. It's 2 o'clock, so I'd like to thank our presenters. If you would like to follow up with any of them, please feel free to reach them at the contact information listed there. And if you require a certificate of completion for the webinar, or you want to hear more information about future webinars, please feel free to reach out to me at the email address listed there, lit@juvejustice.org. And that concludes today's webinar. Thank you for joining us. Our next webinar is scheduled for Monday, November 2nd at 2:30 p.m. Eastern Standard Time, and we'll discuss LGBT youth in the juvenile justice system, creating agency policies for an equitable system on the state and local level. We hope you'll join us again for that webinar and for other future webinars with CJJ. Thank you again, everybody.